Hello.
Hello, how are you?
Hello, how are you?
All
Ibrahim, how
good?
are you?
All
Everything is
good,
good.
thank you.
Ramadan Mubarak.
علينا وعليكم يا رب.
شكرا شكرا
الله
تعاطيك
يبارك فيك.
وعطيتك مقبول.
اللهم آمين.
شكرا. Okay, thanks for joining us. It's a great pleasure and honor to have you. Uh, I know you are so busy these days, but it's a great
No
pleasure
worries.
and it is so valuable for us that we
No,
have the chance of
no
having a
worries, yeah.
conversation. Yeah, thank you.
My
Okay,
pleasure.
my pleasure. Okay, as
Okay.
long as you have joined us on time, I want to start the session formally. First of all, I want to thank Dr. Ibrahim El Najjar from Egypt to accept our invitation. As long as you know, he's one of the best masters of file retrieval and also a great endodontist, esteemed endodontist all around the world, international speaker and lecturer. And this is a great chance for all of us to learn from his knowledge, experience, and we want to ask our question and to see what is the best approach to manage a broken file. As long as you know, the title of this session is to bypass or retrieve, but we want to expand this subject more and we will ask more questions from Dr. Ibrahim. Okay, Ibrahim, first of all, I want to thank you for joining us. And then if you can give us a brief explanation about yourself and also your journey in the endodontics, if you are interested to talk about, and then we will go for the questions and discussion.
Okay, thank you, my friend. First of all, it's a real pleasure to be with you. And I cannot refuse something like that because um, when it comes to files, it's a priority for me. And for those who are joining us today, I'm Dr. Ibrahim Naggar. I'm a Style Italian Endodontic Silver member, and I have a big interest in endodontics. And today I want to give you some brief on questions that you can get or we can get about how or when to retrieve and when to bypass. And by the end of the session, we will try to show some data about if we are going to do a bypass, how we can do it efficiently and without any problem, um, like uh, like we need something new.
Very good.
Okay,
Okay, have you prepared
so
anything?
what?
Have you prepared anything for us to share, or we can just
Yes,
go straight for the question?
yes, but if we can have the questions, we'll appreciate to get it.
Okay, okay. I will go first for the question. The first question is about the prevention of file fracture, because I think best available management of the file fracture is to prevent it. I want to ask you about the tips and tricks that you follow in order to prevent the file fractures. What can we do and what should we do if we want to have the less rate of file fracture?
First of all, when we talk about the file fracture, it's a little bit multifactorial because file fracture doesn't come only from the file. It comes from the tooth, it comes from the file, it comes from the motor, and it's multifactorial. So you have to take care about every single step of that, and after that we have to think about the fracture. Like for example, if we have a motor and this motor doesn't have any kind of like we say, a safety option inside, like the apical stop, like the adaptive torque control, ATC, what we mean, OTR, anything of that. We have to shift to these kind of motors that can give us like we say, the extra safety for the file fracture or against the file fracture. When we talk about the anatomy, the tooth itself, we have to mention that we don't have to work quickly and work hardly without analyzing the tooth itself, the curvatures and so on, and don't work in hurry because otherwise you are breaking no way. And the last thing I would talk about is the file itself. Why? Because I think it's one of the things that all the people look at, but they miss the other parts. Okay, so for files, I don't want to say or to recommend something special or something other than any other company, but you have to take care. You have to be cautious about the file that you're using. You have to know the design and how to use it because not every files or not all the files works together in the same way. You have to put the file in practice in a correct manner, and also least thing you have to update yourself about if you break the instrument, how you are going to deal with it. This is very important point.
Okay, dear Ibrahim, do you still consider file fracture as a mishap and as a challenge? Because today's we have the dental operating microscope, different tools for file retrieval, but can we say it is still a big challenge and we have to go for prevention, or we can say because there is a quotation from one of the greatest masters of file fracture, Dr. Trauchi, and he said that he will use the file until the fracture because he's completely sure that we can retrieve the files. Are you actually, do you agree with this concept that we can retrieve any file or bypass any files, or it is still a big challenge and we have to prevent it?
If I treat the case and I'm able to save some time for the patient, I would do it. Okay, but I'm not going to use the file until it's fractured and try to retrieve it by wasting like any kind of time for that patient to waste it and to try to retrieve it because I think it's a manner of being honest. If I'm treating
Yeah.
your central I can give you this treatment or this kind of treatment in 10 minutes. So I don't think so that you may be happy if I did this kind of treatment in like 20 or 25 minutes. In both cases, you got the treatment, but the, there's a huge difference between one and two. In the first situation, I treated you and we finished quickly. And in the second situation, what happened? We took from your time, we took from your tooth, and we left metal inside. Of course, for myself, I would not like. Uh, I would not like to have any kind of metal inside my mouth.
Great, great. Thank you. Uh, I think it's better for go for the bypass techniques. I want to start with bypass techniques if you agree, and then we will go for the retrieval. Uh, what are the techniques and what is your approach to bypass a file? And what are the criteria? For example, if it is at the coronal, it is easier to be bypassed about the size of the file. If the file is smaller, is it easier to be bypassed? And what are the criteria and how we can do it more efficiently and more safely? What are the solutions we have to use in the root canal system if we want to bypass the file? I want to go in details about the bypass technique.
Of course, if the file is in the coronal part, it would be much easier to retrieve this kind of fracture or this kind of mishap. Um, but in case of if the file is middle or apical, I would go. Sometimes I try to do the retrieval. I try to do the retrieval or try to create a space for the file to retrieve. If I was able to do a bypass, I would do it. So it depends on the file location, the available space, and also on the available armamentarium and uh, the visibility of the instrument. There is a lot of factors to consider, but we need also to consider the fact that sometimes you need not to interfere with the instrument and know when to stop, because this is very, very important. I would show you a diagram from my presentation. If we have a separated instrument and we have a straight axis, okay,
Okay.
and I don't know, the cursor is showing, yeah. We have a straight axis for this instrument, and sometimes we lack this straight axis, okay? If we have a straight axis possibility, this is the first factor I will consider. um I will consider to, to retrieve the instrument, but sometimes I would lack that straight axis, and I cannot create it, so I would go for bypass. If bypass failed, I would change the treatment, like if I would leave the file or something, and if I succeed, I would do instrumentation and filling. But what if after lacking of the straight axis, I was able to create a straight axis? So I would jump here again and come to this part. So if I have a straight axis, I would look to the instrument alloy. I'm talking now about the retrieval of the instrument. I would look about the straight axis if it's and the instrument alloy, if it's stainless steel or nitride, because people who would work knows too much that there is a lot of difference, a lot of difference between stainless steel and nitride in the retrieval. Why? Because sometimes the stainless steel pretend to have the same shape that the instrument broke inside. Unlike the nitride, when it broke, the nitride broke, what happened? It always lie on the outer wall. So there is a big difference between both of them. Here for the ultrasound and extractor, there are both of them available options for the retrieval of the steel or the nitride. But when we have an instrument length which is long, okay, we would recommend you to go for the extractor, not to cause any kind of secondary fracture. Okay,
Okay.
but if we have the ultrasound, um, uh, if we have the fragment length, sorry, short, and when we talk about short or long, there's a specific number which is about 4.5 millimeters. Ultrasonic is a good option to retrieve. Okay,
Okay.
okay, but if you found that after retrieval that you are not able to get, you would go again to the bypass. So this is the schema that we want to show here when we talk about the fragment length. I would consider sometimes, because people who work on retrieval may consider that uh, um, may consider that the retrieval, that the specialists who work on retrieval may consider that the retrieval is easier for them than doing the bypass, because bypass takes a lot of time and so on. Okay, we will talk about the location of the fragment when we have a high success. When we have the fragment in the coronal land, coronal part, we would say that you have a high success for removal. Sometimes you have the fragment in the middle part, okay,
Okay.
and sometimes you have the fragment in the apical part. When you have it in the middle part, when you have in the middle part, is okay. Sometimes we can do it, sometimes we can retrieve it, and sometimes we cannot. But when we have the fragment in the apical part, it's a must 100% to try with the bypass first. Why? Because the bypass would be easier for you to try to uh, free a space for the instrument up to retrieval. Okay, I'll try to show a video or something. Like you can see here in this case, we have the fragment on the coronal part. So there is no way we are going to retrieve this instrument. There is no option for bypassing. I will leave you with the video. Just in seconds. No way, just um, trying to vibrate the instrument, and then it's kind of easy to put the loop on, and we are done in just few seconds. And this is the real time. And the loop and the file is out. But I would show you another case.
It was a night file?
It was, yeah, it was an ITI one. Okay, I'm trying just to get the case. Here, we face a lot of situations that is like that one. Is like that one because people sometimes broke a lot of instruments with the whole length and is get out of the tooth. So I think that there is no way that you can bypass this one. So here we are trying to just providing a space around the instrument. It is a very, very large file and a long file, and also is extended outside the tooth. But when you have the trust in your technique, you are able to remove it with the minimum dentin loss all the time. Now with the thinnest loop, we were able to retrieve the instrument even it's full engaged inside. Okay, and here you can see that the file went out. But I want to say to the audience something that is not 100% that we remove the instrument, because sometimes we need a little bit of help. Okay, like in this case, I would show you a trick in bypass for retrieval. Here in this one, okay, it was a little bit easy, looking easy, you can see, but I was not able to retrieve the instrument. Why? Because my assistant missed the wire and it was not at the office. The thinnest wire was not at the office. So I have no option except to use the thickest wire. You can see this is a thick wire, not a thin one, okay? And to be honest, I don't like to remove dentin too much. So I told her, no, we have another option. We got a 1503 rotary file in a reciprocating motion and did a bypass with the rotary beside the instrument. By this way, we dislodged the file away Okay, dislodge the file
Great.
fully away, and now you can see that with a little bit of vibration, we get the file out. And with almost no dentin loss. So this this is a little bit of briefing about the separated instrument, but I want to tell you something about bypass that first of all you need to bend the file in a correct way. Don't bend like this, don't bend like this, don't bend like this one. And also you need to differentiate between the files that you are using between the manual file, the normal one, and the dfinder. For me, I use also the dfinder, and I go for a specific technique that I work all the 10 millimeters, all this, okay, to the full length, and after I reach to the working length, I go with the reciprocating handpiece. Why? To secure that the space is very nice, there is no problem, and so on. Okay. After I would go with the 15, after I would go with the 20, and every time, of course, I would place the reciprocating handpiece. But sometimes you are not able to go all the length. Sometimes I can only go with the manual K file for the first 1 to 2 millimeters. Okay, no worries. I would place it, and then I would go with the 15 in the first 1 to 2 millimeters, and then I would go with the 20 for the first 1 to 2 millimeters. Then repeat 10, 15, 20, 10, 15, 20. After a little bit of time, everything is done. You have no problem. Okay. If you try this, I promise you is very beneficial for you. This technique is very, very beneficial. And this is a video for the reciprocating handpiece work. It do like oscillating motions between 30-30 or 60-60, depending on the type that you are using. Do we have any questions till now?
I want to see the pre-bent of the file exactly because I wasn't able to
Yeah,
check the
I would give it, bring it again.
which yeah which
Yeah.
type of pre-benting do you prefer for the bypass? This one is the best. Yeah, I got it. The abrupt curvature at the tip is not good for bypassing because it will lead to another fracture. You mean pre-bent? Yeah, yeah,
This one, not this
continuously.
one,
Yeah.
not this one, not this one.
And what about the solution? What do you use a hypochlorite or
Yeah,
EDTA
I
when you?
use only sodium hypochlorite or EDTA solution. I don't use any kind of gel, any kind of lubricating gels. I don't use, just depending all the way on sodium and EDTA solutions. There is no need, in my opinion, to use the EDTA gel because under the microscope we are able to do a lot of things without trying to go with EDTA.
Okay, thank you. Very good
My
tips and
pleasure.
very uh, impressive videos. Okay, I have some
Yeah.
question regarding the cases that you have shared. I want to know about the movement when you grasp the file. Do you use a counterclockwise movement in order to dislodge the file from the root canal system? And
Yes.
what did?
Yes. One of the things that I discovered that it can decrease the cut of the loop is the way that you move. Okay, because they
Okay,
do a lot of surgeries and extractions as well and impaction and so on. So I'm doing like tooth removal every day. So it's the same idea of bringing the tooth out. Simply is the same idea. You will get the loop with a persistent force. Just it is very important to do that. Persistent force. How? Is just to get the loop and try to pull. Don't do this. Just do a grasp like this and do like counterclockwise, counterclockwise, counterclockwise. By this way, sometimes you will face that the file is dislodged and went out of the tooth.
In this situation, should be the canal in a dry mood or in a wet
Yes,
situation? It
it
should be
have to be
completely dry.
completely dry, not wet. Because if the canal is wet, this will help the loop to dislodge from the file itself.
The grasping is not
Ye-
effective when the
Yes,
canal is
or
wet.
if you are engaging in a maximum engagement and you are engaging an undercut in the file, so there's no worries, but I don't like to do it because I need to visualize what I'm doing.
Very well. As long as you know, we have two types of file fracture: torsional fracture and cyclic
Yeah,
fracture. I want to know the difference when we want to remove these files. Because I have experience of some removing files when we have torsional fracture, it is very hard to remove those files because there's a lot of frictional resistance between the file and the dentin. I want to know that is there any difference between the techniques that we want to
yes,
remove the file?
yes, of course. When we have a torsional fracture, a torsional, the stresses of the file lead to twisting of the flutes. By this way, the head of the instrument is twisted. So if I try to grasp the file, it will dislodge because the head is twisted. And when the head is twisted, what will happen? There is no undercut to place the loop. But when you have a cyclic fatigue fracture, is the file is broke like this. So sometimes you have what we say the undercut underneath the file. Okay,
Okay,
this
okay.
is a very important factor. So this is factor number one. Factor number two, that the cyclic fatigue files are less engaged to the dentin wall. Okay, and the torsional one, no, the torsional one is very, very engaged to the dentin wall. And on the other hand, if I have a torsional file that is being broken, I need to go deeper to engage an undercut, and so I can place my loop. Okay, but when I
Okay.
have a cyclic one, you face the undercut in the very first few millimeters.
So you mean we have to remove more dentin when we have torsional fracture?
Yes.
And what about the location of the dentin removal? Should be it in the inside of the root curvature, or it should be from the outside wall of the root
Not
curvature?
90% of the cases is against the root curvature on the inner wall, on the wall that the file is not lying on. If the file is lying on the inner on the wall, I would hit the against one. I
In
don't
the
have
inner
to.
wall.
Yeah, but in the inner wall is the wall that is against the file. Is not located to the forcation. Is not what we say. Um, is not related to the forcation itself.
Very good, very good. And about the different types of the fracture removal. For example, we have some kit, for example, IRS, IFS, different types of the instrument. But I think nowadays the loop technique is the most common as it's the most effective way. I want to
Yes,
know about the instrument that you use for retrieval.
I
You
I
just
only
use a loop technique.
I only use loop technique.
You only use loop
Yeah,
technique.
I
Yeah,
I don't depend on any other thing. Just loop technique.
just loop technique. And
Yeah,
how
my
much time do you?
opinion.
Yeah,
My opinion that nowadays we don't need any other kind of devices.
devices and
We don't
kits, different kits.
we don't need, yeah.
We
Loop
just
is very
need the ultra.
efficient.
We just need ultrasonic tips in order
Ultrasonic
to
and
expose
loops. That's
loops.
it. Yeah.
That's it.
The average time is
And
about 30 minutes, the whole
the
session.
average time. And about the amount of the dentin and about of the file that should be exposed. How much is enough? For example, 3 millimeter of the coronal part is enough,
Yeah,
or it depends on the situation
yeah, I
that
see
you. Uh,
that 2 to 3 millimeters is way very, very enough to expose or to place the loop in a good way.
3 millimeters is enough for grasping the file very
Yeah,
efficiently. Yeah.
yeah.
And how much time should we spend? For example, I have spent about 1 hour in order to remove the file, but I was unsuccessful. should I stop my attempt, or I
I
can go for
think
another?
after, yeah, I think after 30 minutes, if we are not able to remove the instrument, we have to reschedule the patient. If you are a specialist, if you are not a specialist, I prefer from the first 30 minutes you have to refer the patient and not don't go for another session. This is
Okay,
very, very important to decrease the damage that is happening.
so at this standpoint, we have to change the treatment plan, or should we go for another session and do
If
again another attempt? What is
if we
your
are
option for
if
this?
yeah if we are sure of the treatment option that we are giving for the patient, there's no worries to go for the other treatment option. But if we are not, I would appreciate referring the case to a specialist and changing the treatment option also.
Also,
Yeah.
okay. My question is about the files when we bypass. What types of the files should we use? Finder, I think you said during
Uh,
your presentation,
uh,
or can we
yeah.
use K files if we want to bypass
The
the file?
problem is the cave file is a waste of time because it bends so quickly and is not stiff. I always say it in an example that bypass is like a fight. You are going for a fight. When you go for a fight, you would need a stronger fight. So never ever I would depend on the K file, the normal one, to fight in this situation. I would use also the Finder because the Finder is a stiffer file and it doesn't bend so quickly and so on. It has a more metal core, less fluids. So by logic, it's much better.
What about C files and C pilots and C plus files?
I see them dangerous. In this situation, I see them dangerous.
Why? Because they may lead to
They may lead to a
transportation.
path, other path
So,
for another path, and this may harden the procedure itself.
so in your opinion, the D files is the only and the best option in order to bypass and also
Yes.
prepare the space
Yeah.
between the files,
Yeah. Yeah.
and and there are some claims that we shouldn't use any rotary files after bypassing a file because it may lead to another fracture. But I see that you have used a
You
file
can use a new
to
one.
reciprocate.
Yeah.
It,
You can use a new one.
a new one is safe. You
Yeah.
mean that we shouldn't be worried about
Yeah.
another fracture or
Yeah.
second
Yeah.
fracture?
In a sequence. In a sequence without a problem.
There is no problem.
Yeah.
And also, okay, thank you. And also about using the ultrasonics around the nitrile files. Some claims that because the nitrile files absorb the vibration of the ultrasonic, it is not efficient to use ultrasonic around the nitrile files. And we should use it only for stainless steel files. I want to know your concept about this. Can we use ultrasonic tips for nitrile files?
Yes, we can, but we have to be careful from what we call a secondary fracture, because secondary fracture is something which is very, very dangerous, and we don't want to go through. It's very, very dangerous, and it may complicate the procedure more and more. So, actually, we don't like to do that.
How should we be cautious about that? What are
Yeah,
the
because
points?
you don't have to increase the power, and you have to diagnose the case from the beginning. If the case is having a long fragment, you don't have to do that. You don't have to depend mainly on the ultrasonic because otherwise it will break 100%.
So in this situation, we have to only rely on the grasping technique and try to remove it by.
No, you have to use ultrasonic and grasping technique, but be careful while doing the preparation with the ultrasonic.
Okay, and about the dancing movement, is it necessary to
I see
reach
no.
at the
No.
dancing? You say
I
no.
can say no. Yeah,
It is not
because
necessary to see the file
yeah,
dancing.
because I retrieved the files many times that is not in the situation that the file is dancing.
So in your concept, it is not necessary to reach at the
Yeah, yeah,
dancing
I don't need
level.
it. Yeah.
Okay, for the audience, I want to explain the dancing mode. We have dancing mode when we see the file, when we use ultrasonic tips around the file, you will see that the file goes in the different ways and it is not returned to its original position. We
Position.
call it the dancing. Yeah, we call it this dancing, but based on Ibrahim's concept, it is not necessary to reach this level because the old concept was about that we have to reach the dancing
Reach the
movement and
dancing
then we should,
first. Yeah.
yeah,
Yeah.
but this is the new concept. Yeah,
Yeah.
it's very good. Okay, we have some question with the followers and the participant. I want to go for the questions. One question is about the obturation technique after bypassing file. Is it necessary to use a specific kind of obturation technique, or we can use any types of obturation, for example, lateral
Is
compaction?
not something that you can consider is normal. But you have to take care if you have a perforation after the removal of the instrument, because sometimes colleagues do perforation without even noticing. So you have to consider if you have a perforation, if you have anything mistaken, you have to correct with the obturation technique. But a specific obturation technique, of course, no.
So there is no difference regarding the
Yeah,
obturation technique.
yeah.
Very good. And the other question is about the ultrasonic you use for the retrieval. Can you explain us about the types of the tips and about the kit and everything
Yeah.
that you can explain?
Yeah, I depend mainly on. We have, you know, that we have a titanium ultrasonic tips that, like the traditional one. I don't want to say names, and sometimes we depend on the K files. Okay, there are
Okay.
sometimes we depend on the K files itself. K file are one of the best for me to use because is cost effective and is very very easy and very very thin tips and doesn't produce a lot of dust while working and so on. So it's very nice. I in my retrieval I use three things: liquid,
Okay.
ultrasonic tip, K file, and loop device. I don't use any other thing.
You receive all the files by just
These
these three
three kinds.
instruments.
I may add a K file, D finder, or sorry, or 1503. I can
15 or
say, yeah, I can say, give me this armamentarium and I will be able to retrieve anything you want.
very
Because,
impressive.
yeah, because we don't want to go around complications and to complicate things. Techniques are easy. I just need these things and you are able to retrieve any kind of instrument you are facing.
Very good. And what about when we have the file fracture beyond the curvature, after the curvature, and we are not able to see it? Because there are some techniques that it is suggested specifically by Professor Traucci in order to retrieve a file beyond the curvature, but it may actually lead to many loss of tooth structure. I want to know
Yeah,
if you go for removing the file beyond the curvature.
we have to see the cost and benefits. I tell the patient that we will give one trial with XP shaper or finisher or something. And also I have another technique, but it have a lot needs a lot of time for explanation that I tell for the patient. We would do that. And there is a huge risk that the file goes out.
Oh,
Okay.
oh, yeah.
If it went out, I would close and then I would follow up. If the problem persists, I would do you a surgery. So the patient come to me with a complete trust. He knows that I would do anything for him, but I don't hurry up. If the file went out, I would do a surgery and this kind of stuff. I consider it as a stupid things.
Okay, thank you. And what about bypassing the file beyond the curvature? Is there any specific area that is easier to be bypassed or depends on the types of the fracture and it is case by case? For example, it is
Uh,
easier to bypass a file from the inner curvature or from the outside of the curvature? Um,
I say always inside because it's the shortest way.
oh, so we have to look
Yeah,
for a space inside the
yeah,
curvature and inside the
yeah.
file fracture. Very good. And Also about the solution, to ask more specifically and more details, which one is better, hypochlorite or EDTA? Because some say when you use EDTA, it may lead to the dislodgement of the file from the root canal system. But I want to know your concept about using EDTA and hypochlorite. Is there any difference, and in which stage we have to use it?
I would say that sodium hypochlorite is much, much better. Why? Because when I hit the sodium, it can remove debris, it can get white, and white under the microscope is very, very nice because it increases the light. But for the EDTA, I use it between the head and the head with the ultrasonic. Like I did a head with the ultrasonic and I would stop, I would use EDTA in between to dislodge the debris around the file and clean everything. But when I go to cut again, I would use sodium hypochlorite.
Okay, okay, very good. And the question is about when we are not able to bypass or retrieve, what is the final object? To leave, you go for surgery at the same time, or no, you just obturate the case and wait for the follow-up session and then go for the apical surgery or
To be
any
honest,
other
it
objects?
depends. Yeah, to be honest, it depends on the situation. If I have a very high risk of infection, if I have canals are in type 2 or normal canals. Last thing, there are criteria for leaving the file. If the case is vital, if we are breaking the instrument in the apical part and in the file, if the file is bigger than 3004 or at least 3004, if I have these criteria with me, I would say no problem, I would leave the file and I would follow up. But if they are not, I would say that I would do a retrieval by
Okay.
surgery, of course.
So, yeah, and in such cases, you will go for surgery instantly after you have finished the
Yeah,
treatment.
yeah.
Okay. And about the irrigation protocol after bypassing a file, because some claim that if you use ultrasonic activation when you bypass a file, it may lead to dislodgement of the file and again to block the canal. I want
Yeah,
to know if it is possible to use ultrasonic activation when we have a bypass a file. What types of activation should we use?
you can use ultrasonic, no problem, but you have to place the tip below the broken instrument, not above. You have to use it below. You need to
You mean
bypass
you
the
need to
bypass the
bypass,
file
but
itself with the ultrasonic tip and do hits like this way. I don't know if you will listen. Like this is my hand. It's mimicking my leg movement during the activation. It's like this. But I will not do a long press. It's like this, tick, 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 like this. Sometimes the file come out, not down.
yeah,
If you do that,
not down. Okay,
yeah, you do this, it would go up.
it is very, very good. Thank you. Good point.
Yeah,
Okay, I don't have any other question. I have answered all of my question, and you have completely talked about and share
it,
your knowledge with us.
it's a
If you have any,
pleasure.
it's a great pleasure. If you have any final comments and words about the file fracture and file retrieval, we are all ears, or we can finish this session. Any final words? Okay,
So
there is
the
no.
next one, we would talk about the surgery. We would prepare another live for the audience, talking about the surgery. And we may complete the circle by talking about
Exactly.
when to go, uh, when to go for surgical file retrieval. This
Thank
this
you.
will be very nice.
It will be our honor and pleasure to learn from you about the
The
microsurgery.
pleasure is all mine, my friend.
Thank you, because I know
Mhm.
you have performing and executing different courses regarding file retrieval and
Yes,
also endodontic
yes,
microsurgery.
yes.
and for me, the microsurgery is the field of my interest. But I know I am not as good as you, and I'm very eager to learn from you to improve my skills and to improve my
We will
knowledge.
prepare another one. Yeah, of course.
Thank, thank you. So
So
the next title
this
is
time, yeah.
ready,
Thank
and
you. Thank
we
you
can
all
plan
for
for it.
joining us today, and see you
Thank you.
soon. Thank
Thank
you.
you. It's a great pleasure. Have a good time,
You too.
and God accepts your prayers
You
and
too.
your fasting. Thank you. Thank you.
Okay,
Have a
thank you,
nice
my
night, my
friend.
friend. Have
You
a nice
too. Bye
night.
bye.
Thank you. Thanks
Bye.
for accepting the invitation.
Bye.
Bye.